On to our next speaker, Dr. Anamika Patel, again another young ophthalmologist in our group now of webinar, consultant vitreoretina, uvea and immunology services at Visakhapatnam Center. And she is going to be talking on role of FFA and wide field imaging in anterior uveitis. On to you.
Thank you, Dr. Chitra. So good evening, one and all. It's a great pleasure to present our work on this podium, and I would like to thank Chitra and Dr. Chitra and team for us to give us this opportunity. So today, this evening, I'm going to speak on the possible role of a fluorescein angiography, the wide field fluorescein angiography in anterior uveitis. In this presentation of mine is rather a thoughtful, thought-provoking presentation where you are going to look into the slides where you are going to see some changes in anterior uveitis in the wide field fluorescein angiography, which may pose some questions to your mind. That is it of academic or a clinical interest? Does it really help in changing your diagnosis? And does it really influence the treatment and the outcomes in your patients? So let me start with a very common and a very known presentation of a disease known as Behçet's disease. Now, Behçet's disease, as we all know, it presents with a hypopyon, rather a cold hypopyon. And these patients, when they have this very classical history of a recurrent mouth ulcers, and if you get to do a fluorescein angiography in such patients, like what you can see here, that there is a presence of a disc hypofluorescence. We can see the presence of a cystoid macular edema. But what is largely hitting the eye here is the presence of this beautiful ferning. Now, that's the way how we, with the help with our fluorescein angiogram, we clinch the diagnosis for the Behçet's disease. So I have given you an example of usage of a fluorescein angiography in an anterior uveitis presentation of a Behçet's disease, where the ferning mostly clinches the diagnosis. But what about the other cases of other non-granulomatous anterior uveitis presentation? So let's take a look at this patient who presented with the complaints of redness and photophobia and had 2+ cells on anterior segment examination. So the diagnosis of left eye acute non-granulomatous anterior uveitis was made for this patient. But if you look into the fluorescein angiography, the wide field of fluorescein angiography here, there's the presence of this very subtle peripheral retinal vascular leakage. So now a case like this, where though your clinical acumen tells you that you are dealing with a case of non-granulomatous anterior uveitis, but the fluorescein shows you a picture like this. So would you now question the very diagnosis that am I dealing with anterior uveitis or is it an intermediate uveitis? So what could be the hypothesis? So the logical thinking would be that if you see peripheral retinal vascular leakage in a patient with anterior uveitis, as we know that classically in anterior uveitis, the iris and the ciliary body inflammation happens. But given the very fact that we are seeing the leakage, the peripheral retinal vascular leakage, it would mean that the peripheral retinal vessels are also involved in the terms of inflammation. So the two hypotheses that is there in literature, which I would like to quote, is that the first is that it could be a spillover from the anterior segment, the inflammatory mediators from the anterior segment to the vitreous. And the other would be the presence of the systemic inflammation itself. So now we have seen just a case of an anterior uveitis where we saw the presence of the peripheral retinal vascular leakage. How about an association with the systemic inflammation? Do we have a scientific evidence for that? So yes, there is a study which I would like to quote here, where the peripheral retinal vascular leakage was found in about 44% of the patients in the anterior uveitis, where the association with the ankylosing spondylitis, JIA, TINU, and the sarcoid uveitis was made. Now, another possible fluorescein picture in anterior uveitis that one you may get to see would be a presence of a cystoid macular edema, or a presence of a disc hypofluorescence. To sum up, the three fluorescein angiogram pictures that one may get to see in a case of anterior uveitis would be when you're doing the white field, you'll get to see a presence of this retinal peripheral vascular leakage, peripheral retinal vascular leakage, followed by the optic disc hyperfluorescence, and in some cases, the cystoid macular edema. So I've spoken about the cases where the inflammation was active. But what about and how about those cases when you see such peripheral retinal vascular leakage in the quiescent disease where the anterior uveitis say has resolved? So let me take you through two clinical case scenarios. Let's say for the patient one, we had this patient who had this persistent inflammation with the resolved anterior uveitis. So now, does it suggest the possible incomplete quiescence of the systemic inflammation? Because we know that about 44% of the patient, they may have systemic involvement. Or when you see again a patient like this, where this is a fluorescein angiography of a patient with the resolved anterior uveitis, where you see the disc is hot, you see the cystoid macular edema, and then you see the peripheral retinal vascular leakage. So what next? Does it mean that there is still a presence of a systemic inflammation here, though the anterior uveitis has resolved? So to sum up, with this presentation, I would like to conclude that white field fluorescein angiography in anterior uveitis, the three prominent features that you may get to see would be peripheral retinal vascular leakage, cystoid macular edema, and the disc hyperfluorescence. Now, such changes can be seen both in active and in inactive state. But when you see a peripheral retinal vascular leakage, they may be associated with a systemic disease. And patients with the peripheral retinal vascular leakage in an inactive form, they may require close follow-up for the possible recurrence and the systemic association. I thank you all for the patient listening.
So then, does it mean that you treat the eye when it is asymptomatic also, or do an FFA for an asymptomatic patient also in Behçet's?
I have been doing for the fluorescein angiogram for my patients of Behçet's, even if I feel that only the anterior segment is involved, Dr. Chitra. And we have seen the evidence of the presence in an active form. The presence of a fawning is very classical.
Chitra, can I make a comment?
You should not really capillary farning should not take as a diagnostic sign of Behçet's disease. You can see severe intermediate uveitis, capillary farning. I had discussion with Dr. Tutkun Turkey, who sees a lot of Behçet's disease. She says that you can see it in non-Behçet's conditions like, intermediate uveitis. So you need to be careful about making a diagnosis where there is no oral or genital ulcer. If you see capillary farning and then make a label it as a Behçet's disease.
I would like to make a comment. Can I?
Yes, please go ahead, ma'am.
Yeah. Wonderful, Anamika. I would just like to tell you that anterior segment predominant inflammation, if you decide to do wide field and you see some peripheral leakage or whatever, it does not become intermediate because it is the predominant site of inflammation that will determine the terminology or the nomenclature of uveitis. It will still remain anterior uveitis with some changes, which we are all seeing even in diabetics and others. We really do not know the significance of this small leakage in the extreme periphery. So I will not really try to give the message to our youngsters that if you see anterior segment, you have to, anterior uveitis, you have to do wide field angiogram, not really. And secondly, if you see something, you start looking for systemic investigations, not really. I think it will all depend what phenotype of anterior uveitis they are seen based on their clinical judgment, which should determine whether they are suspecting systemic associations or not. The angiogram cannot guide you whether to look for it or not.
I agree. I agree with Vishali completely. Just because peripheral leakage is there, we need not suspect systemic disease. And Rosenbaum has clearly mentioned the retinal vasculitis very, very, very rarely associate with systemic problem. It is always isolate. So as you mentioned, wide field angiography is not always needed in anterior uveitis. And I also agree with Dr. JB sir. The fan pattern is seen both in Behçet's as well as intermediate uveitis.
Yeah, but
in children, we see it much more common actually when we do for intermediate uveitis, pars planitis, when we see that typical fern-like pattern. And many times there's a nice paper also which had come out where they've classified the leakages over a period of time, and they've looked at central leakages, peripheral leakages, and diffuse leakages. So the peripheral leakages are usually not associated with decrease in vision over a period of time. It's predominantly the diffuse leakage when present, if left untreated for a long period of time, can impair visual acuity. But I agree with Dr. JB, Dr. Ratnam, and Dr. Vishali that we don't really do FFA for all our patients with anterior uveitis.
It doesn't change in the treatment strategy.
Yeah.
Not, yeah.
Anything to add, Dr. Avinash, before we go on to our next speaker?
I think the reason why this presentation was made just to emphasize the fact of a lesser known condition what we generally don't do. That's the reason why this presentation was more of thought-provoking, not in terms of making or altering the diagnosis. This is something which we are not, we don't do it regularly, and even we don't. There's a great paucity of the literature just because we don't have something concrete to offer to the world at this point. It just makes us understand a little bit more of this particular disease, which we had otherwise just limited or compartmentalized to cells in the anterior part of the eye.
I would just like to ask Dr. Avinash and group, actually, when they did the anterior segment, was it the group with HLA-B27 which they did? Because there the inflammation is predominantly ciliary body, it starts off. So again, is it something where their cases, mainly those where they had a bit of vitreous cells also in this group, which you had the leakage?
Anamika, do you want to take it or?
Yeah, so thank you for the comments. So Dr. Kalpana, these cases were not HLA-B27 anterior uveitis cases. These were only had presented with either a fibrin or just 2+ cells presentation.
Yeah.
And the etiology still remains to be undifferentiated post thorough workup. Thank you.
Thank you, Anamika. Those were great cases, and I think maybe wide field angiography does kind of add more to our knowledge. It's probably making us realize a lot of other things which till now we had never explored earlier. So like what you had shown in your cases, while at this point of time, it may not be very significant in terms of making a clinical decision, but it does add to our knowledge. And there is definitely, like what Dr. Avinash said, a definite paucity of literature. So we still need to explore more the role of wide field angiography in these entities, which till now probably we have not done in that much detail as what we can do in future. So thanks for those great cases. And maybe we can now move on to the next speaker, please.